Hello, I'm Shelley Gladstein. I want to welcome you to Osteo Boston and the National Osteoporosis Foundation of New Mexico, where we're presenting tonight and hosting a wonderful speaker by the name of Dr. Deva Boone. And Dr. Deva Boone is an expert in the field of parathyroid glands and surgery of them and the healing of that your systems from that. So I'd like to have her be presented tonight by Barbara. So I'm going to switch and have you do that, Barbara.
Hello, everyone. This evening, our guest speaker, Dr. Boone, has dedicated her career to the understanding and treatment of parathyroid disease. She combines her knowledge, experience, and compassion to provide world-class care to all of her patients. After obtaining her doctorate of medicine at Cornell Medical School, Dr. Boone completed a general surgery residency in New York City and an endocrine surgery fellowship in Chicago. She subspecialized in parathyroid surgery. Dr. Boone went on to become the medical director at the Norman Parathyroid Center in Florida. She now has a private practice in Phoenix, Arizona. Dr. Boone has performed over 5,000 parathyroid operations and has consulted with thousands more patients with suspected calcium and parathyroid abnormalities. Very few surgeons worldwide have treated more parathyroid patients than Dr. Boone. She is a frequent speaker on parathyroid disease and enjoys teaching both patients and physicians. We warmly welcome you, Dr. Boone, to Osteo Boston.
Welcome.
Thank you. Hello, everyone. I'm very excited let me see. Very excited to talk to everybody tonight. So I have a couple of slides. I don't want to get too bogged down in slides, but just to give some background for everyone so that we're all on the same page, I figure it might help just to do this. And if you can't hear, Shelley, I guess you'll let me know or just wave to me or something. I'm going to try to share my screen now. Okay.
Great.
Okay. Can everybody see the
Yes.
slide? Okay. So I'm going to talk about your parathyroids and your bone health. A lot of people don't even know that they have parathyroid glands or what they are until there's actually a problem. So I'm going to explain just what they are and why you should care if you are interested in bone health. So the parathyroid glands are these tiny glands that sit next to your thyroid. They are separate from the thyroid, but they're called parathyroid because they're just located next to it. And when they were first found, we didn't really know what they did. So we called them parathyroid, just purely descriptive. They're tiny glands. They're about the size of a grain of rice each. They're these little red things. There are 4 of them. They're not exactly in these locations, but they're close enough. They're around the thyroid. They're not related to thyroid function. So if you think about the thyroid being, metabolism and regulating those aspects, it's different from that. The parathyroid glands are actually very simple, and they do only one thing, which is regulate your calcium. Everyone on this call, I'm sure, has thought about calcium and listened to talks about calcium. And so I just want to cover some of the basics of why calcium is so important. Most people on here probably think about calcium in relationship to the bones because calcium is the most abundant metal in the body. It is essential for our bones, for the strength and formation of our bones. So it's pretty important to us as humans. Just being able to walk around depends on having calcium. But the parathyroid glands do not regulate your bone calcium. They actually don't really care so much about your bone calcium. We have these tiny little glands regulating our blood calcium level because our blood calcium is actually super important and for multiple reasons that actually don't include the bones at all. So If you have done any biology, then you might recognize some of these diagrams. Don't worry, there'll be a quiz at the end, but it's not very difficult. But you don't need to remember this too well, but just need to remember this is what's happening in the nervous system. So at the end of each nerve, there's kind of this synaptic terminal where you have one neuron giving a signal to the other one. Calcium is actually pretty essential in that process. So that's one way in which it's essential. And this actually is for all throughout the brain and the peripheral nervous system, and even kind of with signaling within the heart, anywhere there's sort of nerve signaling. It's also pretty important in cells. Within cells, all of our cells are kind of talking to each other all the time. Well, they've got this internal calcium store, which is necessary for signaling within the cell and actually from outside the cell. So throughout the cell, we're relying on calcium. And then finally, and this is an interesting one, a lot of people forget, but it's actually really important in blood clotting. So if you remember back to Bio 101, there's all these different factors that have to happen for your blood to clot. And part of that is actually calcium. Calcium was called blood clotting factor 4. So we know about factor 8, factor 7, all these different factors. Well, calcium was factor 4 before we realized that it was calcium. So calcium is involved in all of these things, and that is why you have organs that just regulate your calcium. And it's kind of a big deal because we don't really have an organ for other metals, but we do for calcium. So it's pretty impressive. So your body, your parathyroid glands want to keep this calcium level in a good range for all of these processes, for your nervous system, for your blood clotting, and they have to keep it pretty tight. The calcium level can't vary too much, or all of these processes will not function correctly. So calcium levels vary by age, but you'll notice when you're an adult, by the time you get to about 40 years of age or older, your calcium levels kind of stabilize in the 9s. And this is in milligrams per deciliter. So anybody outside the US, you'll have to translate it, but in milligrams per deciliter is the most common way that we measure it here in the US. And calcium levels tend to be in the mid to high 9s by that point. When you're younger, we actually do see higher calcium levels in the 10s. That can be normal when you're a teenager and in your 20s. As you get to your 30s, it kind of starts to drop. But after that, we keep it in this very, very tight range. So the parathyroid glands, the easiest way to understand what they do is that they are the thermostats for calcium. They are regulating your calcium every minute of every day. They are making parathyroid hormone in order to keep your calcium in that tight range, just as you would in your house if you set your thermostat. Say you set your thermostat in the winter and you set it to 70 degrees. If it's colder than that, the thermostat senses that, it kicks on the heating and it brings it back up. If it gets too hot, the thermostat senses that and turns off the heat. And that's exactly what happens with parathyroids. So as your calcium level drops too low, parathyroid glands kick on, they make more parathyroid hormone. It's the easiest hormone to remember because it's just parathyroid hormone and it's just one hormone. Parathyroid glands are very, very simple. So they make more of this hormone, they raise the calcium level. If the calcium goes too high, they turn off production, which allows the calcium to drop. So very, very simple glands. And this is happening all the time in order to keep your calcium level in a very good range for your blood. Now, what about your bone calcium? Well, this is sometimes detrimental to your bones because parathyroid hormone works in a few ways, but one of the big ways that what it does to raise your calcium, one of the big things it does is actually take calcium out of the bones. Your bones are the major storage location for your calcium. So remember, we need calcium for our brain, for our nerves, for our blood. Well, we've got this huge storage center in our bones, and if we need it immediately, we need calcium immediately, the first thing that's going to happen is we're going to take it from the bones. So look at this part of the diagram. This is one of the main things that PTH is doing. You'll see the little parathyroid glands up here at the left. They are making parathyroid hormone. It goes to the kidneys to do some things there to help keep calcium from going out into the urine and also to activate vitamin D so that we can absorb calcium. But you'll notice one of the big things it's doing is going to the bones, straight to the bones, and taking calcium out of the bones, all to help raise the blood calcium level. So when there's a problem here and there's too much PTH being produced, you're continuing to lose calcium from the bones, which can then cause osteoporosis down the road. So the best way to think about this parathyroid disease is that parathyroid disorder is a disease of calcium. When you're thinking about it in general, just think about calcium and remember that thermostat. So I'm not going to show you too many more slides because I think we've got the background, and then I just want to cover kind of how to look for parathyroid disease, how do you know if you have it, and what it might do. But remember, parathyroid disease is a disease of calcium. If your calcium levels are not in range, in the normal range, that can indicate some problem with your parathyroid glands, and usually does. And that's high or low. We don't want your calcium level to be too far out of this range in either direction. You will run into problems if your calcium levels are in the 10s and you're 50 years old, or if it's in the 8s and you're 50 years old. You really don't want calcium levels that are outside this range. So the most important thing with all of this is to check your calcium, because this is going to tell you whether you need to look into having a parathyroid problem in most cases. There are a few cases in which you can have parathyroid disease contributing to osteoporosis while having an abnormal calcium, but in most cases, an abnormal calcium is kind of the first and biggest sign that you will see that confirms you have a parathyroid issue. So now I just want to get into it. So when I say check your calcium, does everybody here know what their calcium levels are? Is it possible to ask questions?
Yes, I think that a lot of us might.
Okay, yeah. So
Many of us might, or we could look it up if we don't.
yeah, so
A
you
blood
should
test.
be able to. I mean, all of these labs usually give you access to it. You have to check your calcium. You have to know what it is. Now, the big thing that I treat is called primary hyperparathyroidism. And what that means is it's a benign parathyroid tumor, typically, that is just making too much PTH. So it's not doing the thermostat. It's a broken thermostat, right? It's 90 degrees and it's still making still turn the heating on. So this is when you have too much parathyroid hormone production, and your calcium level in your blood continues to rise because of that. So if your blood calcium level is high, most often that is due to primary hyperparathyroidism, a parathyroid disorder, because if your calcium level is high, remember your parathyroid glands should just shut down. They should stop making hormone, and it will allow the calcium to drop. So first thing to look for is high calcium. If you are over the age of 40 and you've got calcium levels above 10.0, that's not normal. That's in the high range. The lab won't always say it. Our labs really vary a lot in what they call normal, but the range that they use for calcium is typically way too broad. So they'll give a normal range of 8.8 to 10.4. 8.8 is way too low and 10.4 is way too high. You really want to see your calcium level in the mid to high nines, maybe 9.3 to 9.9. That's kind of the range where you want to see it. If you have calcium levels that are consistently above that, or you have multiple levels above that, that's not okay. That needs to be further investigated. And what you do in that case is you actually measure the calcium level and the PTH level together, which typically gives it to you. So a high calcium level, remember I said that should turn off the parathyroid glands. So if you have a high calcium level and a really low PTH level, below normal range, that would be appropriate. So that means something else is causing the high calcium. But if you have a calcium level that's high and a PTH level that's also high, or even a PTH level that's in, quote, normal range, that is inappropriate, and that is diagnostic in most cases for primary hyperparathyroidism. So that's the big thing that I think, often gets lost is people are walking around with these calcium levels that are, quote, just mildly elevated. Their doctors, may tell them about it, but they kind of blow it off like it's just a little bit high, it's not a problem. But meanwhile, you're developing osteoporosis because the parathyroid glands are continuing to take calcium out of your bones in order to keep that blood calcium up. So it's not really a benign condition. even if your blood calcium is benign in the sense of harmful, not in the sense of cancers. These are not cancers, but it's not a harmless condition to have a mildly elevated calcium. It is a problem because that calcium is coming from somewhere. It's coming from your bones. And one of the big misconceptions about this is that if your calcium level is just a little bit high, that you don't get symptoms. You actually get a lot of symptoms, not just osteoporosis, but fatigue, brain fog, things that a lot of people are told is just menopause. It's very common for people to have these kind of non-specific symptoms that really affect quality of life beyond just getting osteoporosis and fractures. So first thing is, check your calcium. If it's high, if your doctor's ever even mentioned that it's high, definitely get your old labs, look at them, and ask to have that PTH level checked in addition to a vitamin D level. Vitamin D is important, but I can spend many hours talking about that, so I'll skip that for the moment. But the other thing is, if your calcium level is too low, that's a problem. Calcium levels that are low, your calcium level really shouldn't be low. Your parathyroid glands are going to work hard to keep it in normal range. Sometimes they can't, which means that you end up with these chronically low calcium levels and rising PTH levels. So often what you'll see is kind of low calcium levels and then these high PTH levels. People will come to me because they're worried that that's a parathyroid tumor, but it's actually what we call secondary hyperparathyroidism, which is when the parathyroid glands are overactive. They're making too much PTH. They are causing osteoporosis because they're pulling calcium out of the bones, but they're doing it because they're trying to get the blood calcium level up. And if they can't do that, they just keep churning out parathyroid hormone. Now, remember, the major storage spot for calcium is in your bones. So that's the place they're going to get it if you're not getting enough through your intestines. Because really, humans can only get calcium from two sources. We can't absorb it from the air. We don't breathe it in. We can either get it from our diet or supplements, something through the intestines, or from the bones, which is where we store our calcium. So if you're not getting enough one way, your parathyroid glands will take care of that and take it out of the bones.
Dr. Boone, may I
Yeah,
interject with a question for you? Sorry, this is Shelley again.
yeah.
I just wanted to say, someone keeps asking about what was the range for starters on the calcium again, that for someone that's through menopause or
Sure. Yeah.
over 60, let's say.
Yeah. So ideally, you want to see it in so I say mid to high nines. Now, everyone's a little bit different on the lower end. So sometimes I'll see people with calcium levels of 9.2 and it's normal for them and their PTH level is fine, indicating that their parathyroid glands think it's okay. But I also see a lot of people with 9.2 levels, which are called normal. I see them getting secondary hyperparathyroidism. So anything above 10.0 is too high. And anything below 9.1 is clearly too low. But for a lot of people, anything below 9.4 is often too low. So if you see your calcium levels and they are consistently 9.2, 9.1, 9.2, check your PTH level. If your parathyroid glands are trying to get that calcium up and they can't, your PTH level will be high. Now, the PTH range is typically given as about 20 to 60. It's in picograms per mil. So somewhere in that range is given as normal range. Most people are probably sitting in the 30s and 40s most of the time. If you have secondary hyperparathyroidism, it will tend to go higher and higher and higher as you let the problem go because you have to take more and more calcium out of the bones. But does that answer the question of what is normal?
Yes, I think for the calcium reading, it should be in the mid range of the nines. And for
The
the
high, mid to high. Yeah,
mid to
9.9 is
high.
perfect. I mean but the thing is you kind of have a set point. So some people do have set points in the low nines. They'll range between 9.3 to 9.5. If your PTH levels are in the 30s with that, then that's okay. That means your parathyroid glands think that's all right, right? The parathyroid glands are reacting. They think it's okay. If
What
your
if they're in
calcium
the
level is
20s?
consistently below that, the parathyroid glands are going to make more hormone. So you're going to see that hormone rise pretty quickly.
I see.
Dr. Boone, I have a question for you. So
Yeah.
I put it in the chat, but I'm not sure you saw
Oh,
it.
for some reason, I'm not seeing the chat. Okay.
So I had a recent calcium test. I mean, this is within the last few months, and the range given by Quest for normal is 8.4 to 10.2, I think. And so that the 8.4 would certainly be low based on what you're saying, yet according to Quest, it's in the normal range.
Yeah. Yeah, I know. So you would think it'd be easy to fix this, but it's not. And I have to explain this to people a lot because it isn't something you can easily fix. All of these labs have very different ranges that they give, and they may say 8.4 to 10.2, but it is not normal. Most people really feel better with calcium levels in the mid to high nines. So it's not normal. I mean, you know,
Interesting,
Quest
because
calls it
I
that,
also,
but it's just not.
an
And one of the,
endocrinologist didn't even say anything about it, which is kind of scary.
what was your, well, the endocrinologist, typically your doctors are checking a whole range of things, and they're
Yeah.
just screening for the red ones, the ones that are outside the range. So they'll just sort of screen down, and they won't actually check the individual levels. Calcium is one where you really need to. And you know, trust me, I wish I could fix this. I wish that the labs would kind of give more accurate ranges, but they don't. And part of the problem is that they're in their sample sizes, right? They're actually getting patients from all over. When you're in the hospital, patients in the hospital pretty much always have low calcium levels. Their calcium level tends to drop when they're admitted to the hospital for multiple reasons. One is they're usually on IV fluids. It's getting diluted throughout the day. So the calcium level in particular seems to be sensitive to that, and it is universally lower in inpatients compared to outpatients. But with these labs, they kind of take all of these averages together. So they're taking people with parathyroid disease, they're taking people with, you know, who are in the hospital, who are very sick. They're taking all of this together. Another reason your calcium level drops in the hospital is if your albumin level is low, but there's just multiple reasons why you see variations in calcium. But for most people walking around, you've got normal albumin levels. Your calcium level really should be in the mid to high nines. And, you know, I can say this till I'm blue in the face, and you can say, well, but Quest says it's normal. I treat this all the time. I mean, I treat lots of people who come to me with calcium
I
levels.
believe you. I believe
Yeah,
you.
it's just hard because I want to be able to prove it to you, but
yeah, no, it's just crazy. You know, Quest is one of the major laboratories in the US, and you'd think that they would try to get it right. So
and they're all like,
puzzling.
yeah, it's unfortunate because they're all kind of like that. And the range they give varies widely from lab to lab. And of course, that's not really true. Most humans are kind of the same. But you know, you'll see a lab that'll go up to 10.6 for normal, another it's 10.1. And they're not correcting it all for age beyond pediatric populations, which really causes confusion because a 10.2 is normal for a 25-year-old, but it's not normal for a 60-year-old. But unfortunately, there's no distinction made there.
Okay.
Dr.
All right,
Boone,
thank you.
Dr. Boone, let me bring myself up and ask you a couple of questions. I think one of the things I saw is that on your website, you have an actual way to determine based on age and calcium level and your parathyroid. If you put all those things in, it's an equation basically to see if you're normal or not.
I know. I was thinking I should have put the little link up to that because it's kind of a cool thing. It's on my site, the southwestparathyroid.com. It's a little app that you can go to and kind of plug in your age, calcium, and PTH if you have them, and it'll give an assessment and it'll kind of tell you, yeah, you need to worry about this, or no, this is normal range, or anywhere in between.
I'll post it for everyone.
Great. Thanks.
Okay, so no worries. I'll put it on the YouTube too. I just wanted to also ask you, so the parathyroid, if someone has a very low parathyroid, which maybe could be 25 or something like that, is that a low one?
No, 25 is normal. But with all of these things, well, continue with your question though.
Okay.
Yeah.
Whatever, if the ratio was off in using the formula, so to speak, would that be a sign that that would definitely be a parathyroid issue that we should have you take a look at. There's no other test, in other words, that
So
that you would.
the thing about parathyroid hormone and PTH, and the thing that I try to emphasize to everyone is you cannot evaluate the PTH on its own. So I get people emailing me and saying, my PTH is 75. Is that a problem? I don't know, because parathyroid hormone is a hormone that is made in relation to your calcium level, and you can only interpret it with a calcium level. So I can't say anything. If you have a PTH of 25, that's actually normal. That's fine. But I can't say anything about it. I can't say whether it's appropriate or not unless I know your calcium level. So if you have a calcium level of 9.8 and a PTH of 25, that's actually perfect. You're perfect. If you have a PTH that is truly low, like 10, sometimes we actually see that as long as you're not on massive amounts of calcium and vitamin D. It might just be that your PTH, your parathyroid glands didn't need to make as much hormone that day. But we do see, if your calcium level is normal, rather. But if your calcium level is 10.5 and you got a PTH of 25, that's a little unusual. It's not typical for high calcium caused by outside causes, outside the parathyroid, and it's not typical for parathyroid disease. When you do see that is actually in vitamin D toxicity. And I know this group probably loves talking about vitamin D as much as I do. Um, I am a little bit biased because I tend to see people with vitamin D toxicity. And what happens with vitamin D toxicity is they come in with high calcium levels. So they'll come to me, they feel unwell. They have the classic symptoms of parathyroid disease, and they usually have a calcium level that's in the low 10s, low mid 10s, so they may have a 10.4 and it's been going on for a while. And I check their vitamin D level, and the vitamin D level is not exceptionally high. It might be 70, which if you check your lab range, that's right in the normal range. But check the PTH and it's often on the lower end of normal, kind of low-ish normal. That's vitamin D toxicity. And what you do there is you stop all vitamin D supplements. You have to wait a few months because it does take a few months for vitamin D to work its way out of your tissues. And then after that point, once you repeat it, most people at that point will have normal calcium levels when the vitamin D drops below 50. Now, I know this is hugely controversial because there's a lot of people out there who want to keep their vitamin D level very high and they want to take massive doses, but there is actually very little evidence that really high vitamin D levels provide any benefit. So yes, getting your vitamin D level above 12 or above 20, absolutely. We have lots of evidence that there is a huge benefit to getting it above that range. Above 30, maybe. There's some evidence that maybe that helps, especially in sort of infection and those kind of things, pulmonary infections. Maybe that helps. But getting it above 50, that's where you really don't see a whole lot of evidence for a big benefit. So I tell people to keep it in the 30 to 60 range because that's really where we see a benefit, where we don't see harm. When it's above 50 is where I see people with vitamin D toxicity. And that's where I have to just counsel them on stopping the vitamin D. And I know their doctor probably put them on 5,000 units a day and just told them to go on their way. But that's a pretty high dose. And most people, unless you've got some sort of metabolic problem with vitamin D metabolism, you don't need more than 2,000 units a day, or if even that. So I think, vitamin D toxicity is a big one that I see causing high calcium, which is not parathyroid disease caused, but is simply a cause of the vitamin D. And unfortunately, you get all the same symptoms other than the bone loss, but you get the fatigue, the brain fog, all of those other issues.
Very interesting, especially we've just had a speaker talk about vitamin D probably 2 months ago, and he was very much a proponent of high levels of D. And
I know him, yeah.
I know, and I can understand what you're saying now because I was on vitamin D at a high level,
Yeah.
and it was I think I got my vitamin D up to over 90.
Yeah.
It's
And you might have
terrible.
been able to tolerate that, but you also might not have. And the sad thing I see is that these patients will be on high doses and it doesn't cause a problem. And it will be okay for several years. And then suddenly, Whether their tissues are kind of oversaturated with vitamin D, I don't know. But at some point, their calcium level starts to rise and it starts to go in the tens and it starts to stay there. And they feel really unwell. And when I try to say it's the vitamin D, they don't believe me because they're saying, but no, but I've been on this dose for 3 years and my calcium only went high recently. It's like, well, yeah, but that is what happens. That's kind of what I see, is that your system at some point just gets overloaded with vitamin D, or you're saturated with it. And we start to see the levels really spike, and then we see the calcium spike. And I know there are people who reach out to me. A lot of people like to argue with me on this one. So there's lots of people who've reached out to me and said, I've taken 5,000 units a day for the last 20 years and I'm fine. And you are. I mean, there are definitely people out there who can tolerate these higher levels, who don't have problems, who have calcium levels that stay in the normal range. That is, I don't argue with that. I just know that what I see, I see the patients coming to me with high calcium, and the underlying cause is vitamin D. So, yes, I'm getting a selected group of patients because they're coming to me with high calcium, and there are lots of people who could tolerate it. But the thing is that you often don't need that dose, that high of a dose. And so given the risks of high calcium and the need to kind of continually monitor it, why not just keep your vitamin D a little bit lower, is my argument.
Yeah, I like that. Can I ask you some of the questions? Or, one of the things
Yeah.
you also addressed that I've heard you talk about is the surgery itself. Would
Yeah.
you mind elaborating a little bit about that?
Yeah. So, and I can see the questions as I brought them up. But yeah, I
Okay.
will talk about it. So with primary hyperparathyroidism, that's when you get this benign tumor on one or more parathyroid glands. The only cure for this is surgery, and that's all I've done. So I've only done parathyroid surgery for the last 10 years, done thousands. It's a fairly straightforward operation in that, straightforward in conceptualizing it. So I'm going in through an incision here. I look at all 4 parathyroid glands, find the ones that are bad, take those out, and that's kind of it. It's outpatient. It's about half hour. It's an under an hour procedure. And most patients do very, very well. You really only need 1 parathyroid gland. So if we had to take out 1 or 2, you've got extra. It's the only thing in your body that you have 4 copies of. So you've got extra. Sometimes, in about 10% of cases, patients will have hyperplasia, which is enlargement of all 4 parathyroid glands. And in that case, you don't want to take out all 4. You have to take out, 3, leaving at least part of 1 in there. And that's kind of where you really want to have an experienced surgeon. You want to have an experienced surgeon for this operation because it is difficult. It's hard to get good at unless you've done thousands of these. So it's one of these operations where, you know, you have a higher rate of complication and a lower cure rate with inexperienced surgeons. But I do a lot of reoperations from other surgeons. Most people can get cured. It's a disease that is very curable.
Yes. I really agree with you though. I mean, I'd rather go to someone like you you're really an expert in the field. You've seen
Right.
so many.
Right.
Sometimes I'm always shocked at how many people go to someone that's seen it a few times or something.
Yeah. Yeah.
I
It's
mean,
a tough operation if you haven't done a ton of it. And most surgeons, unfortunately, are doing a few a year, or even 50 a year, but that's only 1 a week. It's not very many. Um, so
um, okay, well, I appreciate that. And so I know we've had a few people have had the surgery. Um, is there a way that when people are taking calcium supplements, do they ever screw themselves up by taking too much calcium that way? Or does that not affect it?
Interestingly, it is much easier to take too much vitamin D than to take too much calcium. It's possible. But usually when I see high calcium levels because of oversupplementation, it's actually due to vitamin D, not calcium. The one time I saw it was when it was a guy who had really bad reflux and he kept a bottle of Tums in his pocket and he just chewed them constantly throughout the day. He was able to actually raise his calcium levels just with Tums, but that is a pretty extreme case. That's a lot of calcium you're taking. So for the most part, it's kind of hard to take that much calcium. But you can do it if you really try. A lot of people will ask sort of if I take it right before the test, will it mess it up? It's hard to say. I tell people to just get your blood drawn in the morning before you take your calcium supplement. That way, you know, if it is going to cause a problem, it won't. But even if you took your calcium levels a few hours ahead, it probably is not spiking that high that it's going to affect the result. But to be safe, you know, so that we get kind of your baseline, get your labs drawn in the morning before you take your calcium supplement.
Someone has these tests done and they go on your website and they plug their numbers in. At what point do they know that they need to have surgery? Are you aware of it right away?
Well, yeah, in most cases, the labs are pretty straightforward. So if you've got a high calcium and a high normal PTH level, I mean, there aren't that many things that can do that. There are very rare genetic syndromes, but for the most part, you've got primary hyperparathyroidism until proven otherwise. And that's actually true for anybody who kind of, if you've had normal calcium levels and then suddenly your calcium level's high and you have low vitamin D levels, because low vitamin D levels are actually characteristic of parathyroid disease as well. But if you have that picture, high calcium, low vitamin D, that's most likely parathyroid disease. I do want to get a PTH, but I mean, you're fairly certain at that point. You know, I operate on anybody with the disease because we know the natural course of it. It doesn't get better on its own. It will get worse. The symptoms tend to get worse. You get more symptoms with time. Your bones get worse over time. You can end up with kidney damage. So all that calcium going through your kidneys can cause chronic kidney disease. You can get kidney stones as a result of that calcium going through. You can get hypertension, cardiac arrhythmias. Remember, because the cardiac signaling depends on calcium. So all these issues can occur over time if you let it go. And that actually occurs whether or not your calcium goes really high or not. So some people will have just these mild elevations of calcium, 10.2, 10.3, that'll go on for years, and they get all the symptoms, they get all the problems. It actually doesn't have to do with how high the calcium gets. So sometimes doctors who don't really understand the disease too well will look at it and say, well, it's not that bad. We'll wait and see if it gets worse. But that's really not appropriate because we know the natural history. The labs may not ever get worse, but you're probably going to feel worse. And the thing that actually drives people to getting surgery more often than bone loss is they feel bad. They have, crippling fatigue and brain fog and insomnia, where they can't sleep through the night. All of these things lead them to have poor quality of life, which then drives them to get surgery. But I typically recommend surgery for anyone who's diagnosed because it's pretty rare to have somebody with no symptoms or no complications from it.
After someone has surgery, do they feel instantly better?
I would love that if they did. No, it takes some time. So right after surgery, so immediately your parathyroid hormone level drops, and then over a couple of days, your calcium level drops. And actually, you feel better in that first day, and then you can actually feel a bit worse in the first week, just because your body doesn't like big shifts in calcium. And then as everything starts to even out, typically in the weeks after surgery, people do feel improvement. So they start to notice more energy, sleeping better through the night, not as foggy. All of that occurs in kind of the weeks after, where you start to notice that. And then other things like blood pressure, your blood pressure can improve in the months afterward. And kidney disease can actually reverse. So you can see improved kidney function in the months after. So it's pretty quick. It's not as you wake up from surgery, but it's pretty quick.
Do you recommend they take a supplement then after they?
Yeah, so everybody after parathyroid surgery should take calcium and vitamin D. I start everybody on that because even if you don't have osteoporosis, your bones have been losing some calcium. There's some calcium that's been leached out of them because of the parathyroid tumor. And your calcium level is going to drop. And remember, I said you don't like big drops. So we want to kind of ease that transition after surgery. So I start everybody on about 1,500 milligrams of calcium a day, spread out throughout the day. And then I taper down over a couple of weeks. But start them out that high dose because, it kind of levels it out a little bit, slows down that decline, and also helps replace the calcium that's been lost from your bones. So even for people with normal bone density, I recommend staying on calcium for 6 months. It's kind of an arbitrary number, but I do want to just kind of replace that calcium a little bit for a little while. And then people who have had bone loss from it, I tell them to stay on it, a lot longer because usually the parathyroid tumor has been there for years working on the
Yeah.
bones, and it's going to take a bit of time to see that reversal. But actually, in DEXA scans, we do see reversal. We see improvements in T-scores, usually in the year after surgery, and then continuing for a couple of years after.
That's really great. May I ask you this, Dr. Boone? How did you get interested in
In
that?
this. Uh, so I did general surgery, which is kind of everything, and the appendicitis to, it's all that. And then I liked neck surgery, so I did endocrine surgery, which is mostly thyroid and parathyroid, more thyroid. I really like that operation. But with parathyroid disease, it's really an opportunity to make a huge difference in someone's life. And it is undertreated, it is underdiagnosed, and it causes significant quality of life problems. I mean, it really does. And partly because it mostly affects women and mostly affects postmenopausal women, it tends to get dismissed. So it gets dismissed as menopause or getting older or anything, all the things that a lot of people have heard. You need to lose weight or you need to do this. And so it's one of these things where you can really make a huge difference with an operation. And I really like being able to do that. And now, since I've been doing only that, I mean, there aren't that many people who have my level of experience and can provide it. So it's a very satisfying career.
You've certainly gotten yourself in a position where you're a leading expert in the country in this,
Yeah.
and very necessary. Let me see if I can take a couple of questions that have come in.
Oh, I can see them. So I see a
Okay,
couple about the
great.
24-hour urine.
Okay.
Yeah, so let's talk about that. So for most people with primary hyperparathyroidism, what happens is you're losing calcium into the urine because the calcium in your blood is just kind of overwhelming. So your kidneys are constantly filtering your blood, and if they're having to filter all of this calcium, it tends to leak in there. So you end up usually with high urine calcium level, 24-hour urine calcium. And spot urine calcium is often unreliable. Even the 24 one is not that reliable, but a spot urine calcium is really unreliable. So I don't even look at those usually. So I usually just look at the 24-hour. But it's not really necessary to make the diagnosis because you can actually see a low 24-hour urine calcium with parathyroid disease. So you probably don't remember my earlier slide, but I talked about a couple of things that PTH does, and one of them is actually go to the kidney and stop the kidney from releasing calcium. So it actually, initially with the disease, the calcium level will not be elevated because the parathyroid hormone is actively stopping the kidneys from releasing calcium. Eventually, that will get overridden. So eventually, the calcium will just leak out and the urine calcium will be high. But seeing a low urine calcium does not rule out the diagnosis. So I don't worry too much for the 24-hour urine calcium. Now, what is a normal range? That kind of depends. It depends on how much calcium you're getting in your diet, et cetera. But typically between 100 to 250 milligrams over 24 hours is about normal. Now, here's the really interesting thing about urine calcium. So I get consults from people who typically they've had a kidney stone, and the urologist checks their 24-hour urine calcium and it's very high. And then they remember that calcium was associated with parathyroid, so they check the PTH level and it's also high. And they get sent to me for primary hyperparathyroidism. Now, remember I said earlier, you can't interpret the PTH without a calcium level. I meant blood calcium. Can't interpret a PTH without a blood calcium level. So if I check their calcium and it's 10.5, which is high, and they have a high PTH and high urine calcium, that's primary hyperparathyroidism. But there's another diagnosis that often gets missed, which is renal calcium leak. So in this picture, I checked their calcium. It's actually low. It's like 9.1, and they have a PTH that's a little bit high and the urine calcium is high. That's actually secondary hyperparathyroidism. Remember, because primary and secondary can be distinguished mostly by the calcium level. If the calcium is high, it's typically primary. If it's low, it's secondary. Secondary means the parathyroid glands are doing exactly what they're supposed to be doing, which is trying to get that calcium up. The reason they can't get it up in this case is because it's just going into the kidneys, into the urine. And that's a problem that is originating in the kidneys, not the parathyroids. So these people usually have normal kidney function, like their creatinine looks normal, their GFR is normal, but for whatever reason, they are leaking calcium into the urine. They're putting too much calcium in the urine. And that is causing the blood calcium to be low, parathyroid glands to make more hormone, and they end up with kidney stones. So that's quite a different issue. So urine calcium can be very helpful, especially in those kind of situations. But often when you're diagnosing primary hyperparathyroidism, 24-hour urine calcium is not really a deciding factor. Now, if anybody on here is thinking about FHH or familial hypocalciuric hypercalcemia, then that is a separate condition. It's called FHH. It is a very rare genetic condition that can cause high calcium levels in the blood, very low calcium levels in the urine. And it can look like primary hyperparathyroidism on labs. It's not, it's a separate condition, but it's, again, pretty rare. Urine calcium is not actually a deciding factor. A lot of endocrinologists will get urine calcium, the 24-hour urine calcium, in order to rule out FHH, but that cannot be done. The way to rule out FHH is actually with genetic testing and really with a history. So if you tell me that everybody in your family has high calcium levels, then I'm thinking, okay, maybe it's not parathyroid disease. Maybe this is a rare genetic condition. If you tell me that, multiple family members have had parathyroid surgery, but oddly they're not cured, well, that's a red flag for FHH. That's really when I think about it. Another time is if you've had high calcium levels for your entire life. So since you were 20, your calcium level's been 10.8, and it's been there since then, and now it's 10.5 and you're 60. Yeah, it's a little unusual to have this for 40 years and not get diagnosed or not have any problems from it. So that's where I would start to think maybe this is FHH, like a rare genetic condition. But urine calcium is not a good test for that. Urine calcium is just not reliable enough, but it is useful in some situations.
Okay, well, that's helpful to know.
Yeah.
Did you finish, by the way? And I feel like I interrupted you.
Oh yeah, no. So
Did
so
you
I
finish
actually wanted to
with-
just talk about this because like this is fine because I don't want to do too many more slides on primary hyperparathyroidism because I have tons of them, but I don't want to do that because I'd rather just explain it. People tend to tune out if you have too many slides. So I just wanted to kind of give an overview of what the parathyroid glands are, why it's important, why the calcium is actually regulated, because I think that helps explain it. If you
Good.
understand that the parathyroid glands are regulating calcium, but not bone calcium. They actually don't care one bit about your bones. They only care about the blood calcium. So most of the time they're working for us in that they help bone turnover. They're very good for your bones. But honestly, they care a lot more about the blood calcium, and that can help you understand most of the parathyroid conditions that are related to bones.
Yeah, I love the analogy of the thermostat.
Mm-hmm.
As if it's on, and it shouldn't be on.
Right, and
It's
that's
already
how
too hot.
that's how I explain the normal PTH level, because a lot of doctors will see a high calcium and they remember something about parathyroid disease. They check a PTH and it's normal. So they'll tell the patient, oh, well, your calcium's a little high, but your PTH is normal, so it's not a parathyroid issue. And I do the thermostat thing. That actually comes from my talks for physicians because I'm trying to explain to them how to think about it and how to understand that PTH being, quote, normal, if the calcium is high, is actually not a normal response. It's inappropriate because this is equivalent to your temperature being 90 degrees and the heat still being on. Even if the heat's on low, it shouldn't be on at all. So your parathyroid glands, if they're still if they're still like making a quote normal amount of hormone, that's inappropriate. Yeah, the thermostat thing is what I tell doctors all the time because I want them to understand that you don't need a high PTH to diagnose primary hyperparathyroidism, contrary to what you might think. Might be intuitive.
Very, very helpful.
I'll try to answer all these questions if you
Okay.
want.
Sure, if you, as many as you have time for.
Yeah, no, I do this a lot, so I'll just go ahead and keep answering. Okay, so yeah, so we mentioned the lab report, the mildly elevated. Someone asked about CTX. I'm gonna leave that for for your other talks. I actually do check this, and we actually do see improvements in bone turnover markers after parathyroid surgery. So it can be helpful if you check them pre-op and then check them around 6 months post-op. So you actually do see improvements in the CTX and the P1NP and all that. But that's outside my scope. So I'm gonna let you cover that another time. Oh, someone asked about kind of mildly elevated. Yeah, I mean, when I say this, you know, I'm saying mild, like as in just outside what we call the normal range. When I'm talking about calcium, mildly elevated is elevated. There's really no distinction. But when talking about PTH, it is a range, and parathyroid hormone level, like any hormone, fluctuates, and especially women will know. I mean, these hormone levels can go all over the place as a normal course of things. And that is true for PTH as well. So if your calcium level is low, your a mildly elevated PTH is appropriate. So I kind of try to get away from the term even elevated or normal for PTH and really focus on appropriate versus inappropriate in relation to calcium. Okay. Someone asked about the calcium supplement on blood calcium levels. Well, so supplements, for the most part, if you have normal functioning parathyroid glands and you're already at normal calcium levels, taking a supplement should not really change your calcium level. The time when it's really important is if you have low calcium levels. So if you're walking around with a calcium of 8.8, the problem there is you're going to develop secondary hyperparathyroidism if you let that go. Your parathyroid glands are going to have to work too hard. And I know there's a lot of people who they're hesitant to take calcium because of these kind of a little bit misleading reports about cardiac disease with it. But what I tell people is basically think about it like a medication. If your calcium level is low, you are deficient in calcium. It is a medication that your body needs right then. And I especially encourage people to think about vitamin D like a medication. But for all of these things that you put in your body, think of it like a medicine. If you need it, then it's beneficial. If you don't need it, then yeah, any medication you take without needing it could have risks and likely will if enough people in the population take it. So I'm sure you've covered those studies about calcium. So I won't go into that. But basically, I mean, the main point is if I gave everybody in the US 1,000 milligrams of calcium a day and they had no indication for taking it, then yeah, I'll probably see some problems for it. But if we're talking about somebody with the calcium on the lower end, not getting enough in the diet, and they have bone loss, well, that's actually a necessary intervention, which has a lot more benefits than risks to that. Okay. So Elaine says you had a parathyroidectomy 2 years ago. The numbers were never extreme, but I had 2 enlarged glands. My labs have not greatly improved. So it depends on what you mean by not greatly improved. If your calcium levels are still elevated, so if your calcium level is still in the tens, then you still have primary hyperparathyroidism, likely. Whenever I deal with reoperations, and I do these kind of Q&As on Facebook sometime, and I cover reoperations, it's always, there's a lot to kind of go into first. One is I always check to make sure I've got the diagnosis right. So maybe this isn't primary hyperparathyroidism. So if all 4 of your glands were seen and biopsied and they all look kind of normal, you know, maybe we're dealing with something else. That's number one. Number two is kind of, I do want to know exactly what was done. You know, maybe your surgeons actually just didn't find your parathyroid tumor. So as I mentioned, I do a lot of reoperations where, you know, surgeons will remove parathyroid glands, but the labs don't change. And that's because they never found the tumor, or there was a second tumor that they didn't look for, and that's why they didn't find it. So yeah, the other possibility is if you know you had 2 truly abnormal glands, it may be that you have hyperplasia where the other 2 are also abnormal and they need to be dealt with. But it's a complicated, it's a little bit more complicated dealing with reoperations. But I would say if your calcium level is still above 10, you need to look into that. Now, I do see a lot of secondary hyperparathyroidism after parathyroid surgery, meaning they go into parathyroid surgery, their calcium is clearly elevated, PTH is clearly elevated, they have surgery, they remove a big tumor, and they don't take any calcium afterwards. And then 6 months later, their PTH level's high again, and they come to me because their PTH level is now 90, but I look at their calcium and their calcium's, 8.9. Well, that occurred because you didn't take enough calcium afterwards. Your bones were still depleted in calcium, and maybe you weren't getting enough in your diet, maybe you had some other absorption issues, but your body is craving calcium. And your PTH is high now, but that's actually appropriate. So your other parathyroid glands are really working hard, doing their job. But this is now secondary hyperparathyroidism because you're not getting enough calcium. And the fix there is to just take more calcium.
Yeah.
And by the way, with the calcium intake, there are lots of reasons why you might have a problem with absorbing calcium. The most obvious ones are things like if you have chronic diarrhea, that obviously if things are going through too fast, they don't have time to absorb. But if you've had a gastric bypass, that's a big one that I see a lot. So big cause of secondary hyperparathyroidism is a gastric bypass because you're literally bypassing the area of active calcium absorption that's in the duodenum.
Wow.
And some things like diarrhea of any cause, like untreated celiac disease, untreated Crohn's, that kind of things, can all lead to absorption issues. But I also just see simply people not getting enough calcium in their diet or not being sure of what they're getting. I'm sure you guys talk about spinach. I tell people to not eat spinach ever. If you're trying to get
know.
calcium, just don't eat it. It's just
I
too
know.
high. It's just that the oxalates are just off the charts, whether you cook it or not. Don't worry. I know there are
Feel
some.
that way. And
Yeah.
all the vegetable milks, the almond milk and the soy milks, they all really inhibit calcium
Yeah,
uptake.
exactly. So I have people who come to me and they're like, I calculate it. I write down everything I eat and I write down the calcium content, and I am 100% getting 1,200 milligrams a day. And I look at their labs and I'm like, well, but your calcium level's still low and your PTH is still high. So it indicates that you're not getting enough. And I can't tell you exactly where it's being lost. If you're eating spinach, that's an obvious one, but you're not absorbing all the calcium that you're taking in. So sometimes you really just have to take a supplement in order to get enough calcium. And that's if your calcium level is consistently low, then you're likely not getting enough, regardless of what you're calculating in your diet. And yeah, it's tricky with people because I like that you're doing that. I like that you're being proactive and looking at it, but honestly, I can tell from your labs that you're not absorbing all of that.
Yeah.
Um,
And people are lactose intolerant sometimes and they
yeah, yeah,
just
and
can't seem to get enough.
yeah, and I don't want to tell people. I mean, milk and dairy has its own issues that are possibly pro-inflammatory. So I don't really want to tell you to go eat a ton, to drink a ton of milk every day. That's not good for you either. So honestly, a lot of times, like the supplement is kind of the least bad thing is to just take a supplement.
Mhm.
Um, okay, so we answered about the urine. When do they need to be removed? I mean, when there's a problem, they need to be removed, which is a tumor or enlargement. Um, okay, Steve asks about the type of calcium level. So the calcium ionized, the calcium creatinine, the calcium randomir. It is confusing. There's a couple that you need to pay attention to, but the big one actually is the total calcium, which is the most common one and which we've all had checked, because if you've gone to the doctor and you've had routine labs, then they've checked your calcium. So it's in the basic metabolic panel, it's in the comprehensive metabolic panel, which are kind of standard, yearly labs. So most people have a calcium. Ionized calcium is a tricky one. In certain situations, it can be more accurate. In reality, for people who are getting their labs drawn at a lab, I don't recommend getting ionized calcium because it's kind of finicky. You have to also check the pH, and it can vary a lot on the pH, and it's just a little more unreliable. So if you're in the hospital, if you're in the ICU and they can't get an accurate total calcium because you have very low albumin levels, ionized calcium makes sense. For people walking around, I don't really order it. One, it costs a lot of money. It's finicky. It's inaccurate. I don't really check that too much.
Good to
And
know.
then the urine. So the random one is a spot check. That's like that you peed in a cup and they check the calcium level. Really inaccurate. If you want to see an actual calcium level in the urine, you have to do a 24-hour, pee into a jug for 24 hours. It's a hassle, but that's what you have to do. So EN asks, why not get a 24-hour urine to confirm the diagnosis? Quite definitive. It's really not definitive. A high urine calcium does not tell you that you have primary hyperparathyroidism, not at all. So renal calcium leak was that one scenario I mentioned, but also there are lots of people with primary hyperparathyroidism, probably about 10% when I looked at it, it was about 500 patients that I had who had had urine calcium levels. About 10% were under 100 milligrams in 24 hours, which is low. It's in the low range. That's a high number. So you really can't use the 24-hour urine for any sort of definitive diagnosis here. If your labs are high, Elaine says, do we still need to take calcium? So if your calcium level is high, I do not encourage people to take more calcium or vitamin D because you can raise it further. And if your calcium's high, it's already a bad thing. With primary hyperparathyroidism, sometimes people will say, well, you know, your blood calcium's high, but your bone calcium isn't. So maybe you take some calcium to help, you know, prevent some of the bone loss. Unfortunately, it just doesn't work like that. Your parathyroid glands, if you've got a parathyroid tumor and it's not really responding to the calcium level overall, taking a little bit of calcium, it's more likely to just raise your calcium further than to really control the tumor. It's not going to affect anything. So I tell people it's counterintuitive, but don't take extra calcium or extra vitamin D if your calcium is high. You want to try to fix the underlying problem. And if that's a parathyroid tumor, then that needs to be addressed.
Good to know.
Oh, Emily asks a good question. When I say PTH, is it PTH intact? Yes. PTH related peptide is totally different. Like it's completely different. Unfortunately, I sometimes see doctors ordering this instead of PTH, and they just click on the wrong one as they're scrolling through. But PTH-RP is actually like a protein that looks like kind of like PTH and can do some of the same things, but it's actually a peptide that's made. Mostly we see it made by certain cancers and certain tumors will make PTH-RP. So it's one of those things we look at if you have high calcium and we can't figure out why, like your PTH intact is low, and we have no idea why, we check a PTH-RP to kind of rule out these rare tumors.
Okay.
So totally check the PTH intact. Okay. Oh, Marianne has a good question. And I'm sure for this group, a lot of people are wanting. So for Tymlos and Forteo, this is a tough one. Your labs are really thrown off by Tymlos and Forteo because they are essentially PTH. So you're essentially injecting yourself with PTH. It is going to affect the calcium somewhat. Now, a lot of people, when they ask about this, you know, why would you inject yourself with PTH if PTH in primary hyperparathyroidism causes bone loss? Like, how does that make sense? You know, because I'm talking about when you have high PTH levels over a long period of time, your bones, you get bone loss, you end up with osteoporosis. But people with osteoporosis can inject themselves with PTH and somehow have bone growth. It's partly to do with kind of the cyclic nature of it. So if you're injecting PTH is actually, it's interesting because it does break down bone, but actually it sort of stimulates bone turnover in the process. So if you get a spike of PTH, you're stimulating that bone turnover, not just the bone breakdown. So Tymlos and Forteo are very good for that, but they essentially are PTH. It's like injecting yourself with PTH. Now, most people actually, in the course of taking Tymlos and Forteo, will maintain normal calcium levels because it's just a little bit of extra PTH that they're giving themselves. But some people will develop elevated calcium levels. You can't really check PTH. I mean, you can check PTH levels in these patients, but it's not exactly accurate because they're also going all over the place. So they're going to respond. Your own parathyroid glands will make a little bit less when the PTH is injected and your calcium goes up, but then it'll bounce back. And so it's not quite, it's very hard to diagnose parathyroid disease in somebody on Tymlos or Forteo. If
So
you have
wait.
persistently high calcium levels on these drugs, first thing I do is say, get your calcium levels from prior to when you started, because your endocrinologist or whoever prescribed it really should have checked a PTH and a calcium level before you started. I mean, that's part of the protocol that they should be following. So if they were totally normal, then it's unlikely that you have parathyroid disease. Unfortunately, I've had cases where I've asked them to get their prior labs, and actually their prior labs indicated primary hyperparathyroidism. So it was actually a major contraindication to taking it, but the doctor didn't quite realize it because the calcium was 10.2 and they called it normal, and the PTH was 60, which is not appropriate, but it was listed in normal range, and so it wasn't diagnosed, and they were started on these medications. Those patients can get pretty good spikes in their calcium because they already have high calcium levels and they already have inappropriate PTH secretion. So they shouldn't be on these drugs. I mean, that they should not be on them at all. But if your labs are all normal, now you're on Tymlos, Forteo, it's inappropriate. It could be a parathyroid problem actually, but you can't diagnose it yet. So I have these people stop and then I recheck labs about 6 weeks after. Theoretically, it should sort of clear out immediately, but sometimes it seems they kind of have a longer effect on the calcium. And so waiting a good amount of time and then rechecking just to confirm that everything's normal is kind of the best thing. But it is hard to diagnose when you're on those drugs. EN says, what causes the tumor growth and why are they non-cancerous? Well, I mean, it just is. It's like any other benign tumor that you can get. A lot of them just happen and we don't have a great explanation. We don't have clear causes for the vast majority of parathyroid tumors. So they're adenomas typically. There are a couple of things that can increase your risk of getting them. But for the most part, most people don't have those risk factors. So things like lithium therapy, taking lithium for bipolar disorder for decades can predispose you to parathyroid tumors. Or even parathyroid hyperplasia. So it predisposes to parathyroid disorders. Another one is these rare genetic syndromes can predispose you to parathyroid tumors. They're pretty uncommon, but things like MEN syndromes and certain other related genes can do it. But for the most part, we don't have a good explanation. It's not like smoking or, your diet. We don't really know. In most cases, it just happens. Tends to be as you get older, and it's more common in women. So it's about 3 to 1 women to men. And it's mostly postmenopausal. So there must be some sort of other hormonal influence there. We just don't really know what that is. But they're non-cancerous. Why are they non-cancerous? I mean, parathyroid cancer does occur. It does happen. It is so extremely rare that most doctors will never, ever see a case of it. I've only seen a couple of cases, despite having seen tens of thousands of patients with parathyroid disease. So it's not something you're really going to run into. And typically, it's pretty impressive. The numbers are impressive. It's invasive. It's very usually pretty obvious, but so rare. Madeline asks, how can you tell if there's a tumor? So this whole time I've been saying, yeah, you got a parathyroid tumor. And I'm only talking about the labs. Most of the time, when you think about, if I told you I had a tumor, you'd probably expect me to like show you a mass on my arm or show you a scan where they can see the tumor. But this is different with parathyroid glands. They start out so small and their tumors are tiny. So a lot of times you can't even see it on a scan at all. You find them when you go in and operate, but they may not show up on any of the scans we have because, the gland is the size of a grain of rice and the tumor might be the size of a pea. They can show up on some scans, but often they don't. We diagnose parathyroid tumors solely based on labs, which is different from most, masses and tumors. Mostly we're talking about seeing it. For this, we're talking about labs. So I know there's a tumor without any imaging done. Imaging is a whole other topic, but just to say you don't need imaging to know that you have a parathyroid tumor, and you don't need imaging to know that you need surgery either.
Most of the tumors that you're taking out are not cancerous. They're just interfering.
Right. They're not cancerous, but they do a lot of damage to you. And that unfortunately some doctors too are like, well, it's not cancerous and you can leave it there. Well, I mean, you can leave it there, but you'll feel it and you'll feel it in your bones and over time you're gonna get the symptoms.
Yeah, I was surprised to learn that and listening to you earlier that some people actually have pain in their bones from this
Yeah.
being able to absorb that
Yeah,
calcium from
bone
their
bone pain
bones.
is interesting because you don't get it with a lot of diseases, but with parathyroid disease, it's pretty impressive. Not everybody gets it, but when you have it, it's one of those things where people, report this very deep ache in the bone, and that is something that does get better immediately after surgery. So when you wake up from surgery, the bone pain tends to be gone, which is very satisfying. Unfortunately, sometimes it can return as the bone remodeling is occurring, but it does improve over time.
If you would like to, just because we have so many questions and they're
Oh
gonna
yeah, we do.
not
Okay.
finish. I mean,
Yeah.
we could actually end the program with maybe one or two more. And
Okay.
if you want to stay after and if for anything, you're welcome to, but I don't want, I mean, this could go on for another hour. And I don't
Yeah, yeah.
want to.
What do you think
But
are the most important questions?
questions, I would say mostly that, I think people are gonna ask their levels a lot, and I think
Yeah,
I wanna make sure that I say that, I saw on your website, there's a way for them to plug those numbers in
yeah,
and to get a real accurate.
yeah.
I was really calmed down myself because I thought, oh my,
Oh, good.
I looked at my own numbers. Um, so I thought that was helpful. And I let me think if there was anything here that I.
Oh, well, somebody said, what is the answer to your doc? I mean, honestly, I don't know if your parathyroids are affecting your bones. There are a lot of other causes of osteoporosis, right? So you may have totally normal parathyroid function and still have osteoporosis. Certainly not everybody with parathyroid disease gets osteoporosis, and not everybody with osteoporosis has parathyroid disease. But there's a significant overlap. And if you have osteoporosis, you definitely want to know your calcium level because that will give you insight into whether or not it might be due to a parathyroid problem.
Yes.
And if your calcium level's high, definitely something to investigate. Get the PTH level, also get the vitamin D, and look into your vitamin D supplementation. So if you're taking lots of vitamin D, even if your level's never been toxic, you probably want to stop if your calcium's high, and then also look into the PTH.
Yes, I loved that. I love that. Is there any kind of formula you could give us to know whether we're taking too much vitamin D? How do how would we
Yeah, I mean,
determine that?
check your levels. That's the only way to do it.
Mhm.
For me, I take vitamin D, but I don't really like getting my blood drawn too much. I'm a doctor, so I don't, I'm a terrible patient, right? I'm supposed to get them drawn at least once a year, but I forget. But I do know that when I wasn't on any vitamin D, my calcium level actually was a little bit low, and my vitamin D was a little bit low too. It was like in the 20s. My calcium level was 8.9 or something. So I started taking vitamin D, and I rechecked, a few months after that. I take a pretty low dose. I take the 5,000 unit pills just because it's cheaper to buy them that way, and then I take it once a week, which works just fine for me. For most people, I say, look, you can safely take 1,000 units a day and not see problems. I really don't see problems with people taking 1,000 units a day. Um, and typically you can take 2,000 units a day. Beyond that, you really want to keep an eye on your vitamin D level. So if you're taking 2,000 units a day, or if you're taking 5,000 units a day, it's okay to do that for a very short period of time. But most people, like vast majority of people, do not need that high of a dose. There are people with rare conditions where they can't absorb vitamin D, they can't process vitamin D, and they need to take these much higher doses. And I see these patients occasionally, and I'm okay with them taking these high doses. But that's because we're following their vitamin D levels, we're following their calcium levels. You have to check those if you're going to take higher doses. And some people are, maybe for multiple sclerosis, there's all these things where we're studying vitamin D, and maybe these higher doses are kind of therapeutic, but you do have to follow it. You do have to follow your calcium level, especially. Make sure you're not overdoing it there. So I would say go by the levels, but if you just wanted to take vitamin D and you don't feel like getting your labs drawn all the time, a 5,000 unit pill per week is not going to cause problems, and it's going to be enough for most people. For me, it keeps my vitamin D in a good range just taking that. So that's what I do.
Good to know. I really appreciate that, especially. And here we are with the foremost expert in the country on the parathyroid glands. And I'm just excited that we have had you here tonight. It's been really something to hear what you had to say, especially about the surgeries you've done. I think you've done over 5,000 surgeries.
Yeah, yeah, at this point.
It's incredible.
Yeah,
If we were to go on your website and find, ooh, my numbers really could be a problem,
yeah.
would it be all right for us to reach out to you
Yeah, yeah. And even
or your
you
staff?
can all contact me directly. Here, I'll just share my
Oh, that would be wonderful.
thing. Um, where is it? So this is my email. This all comes straight to me. And then there's the practice website and also the Q&A site. There's links to it from there, but it answers a lot of questions that you might have. So the Q&A site has a lot of information, but you know, if you have a question, just email me. And on the website, there's also a contact form. All these things come straight to me. So so you're able to reach me.
And you're located in Arizona, Scottsdale area?
Phoenix, Arizona. Yeah. Well, the office is in Scottsdale. Yeah.
Yeah, that's wonderful.
Yeah.
And if, let's say someone on this call would want to have surgery with you, you have your own surgical center at the,
I operate, so actually, so I operate at both a hospital and a surgery center, usually depending on the health issues of the patient. But yeah, we have a lot of patients come from out of state, so it's usually like a 2-night trip. You come the day before surgery and then you stay the day of surgery. Yeah, we try to make it as kind of seamless as possible, and um, I've got a great team of people too, so it's a good experience.
it's really great. Well, I have loved this, and I'm sure there's a million questions for after, but thank you so much for getting on tonight. And you might be hearing from us.
I'm
I'm
sure
sure
there's
you'll
always a
tell
few people who have high calcium levels and haven't gotten them quite diagnosed yet. Yeah. So if anybody has any questions, just reach out.
Thank you.
Thanks very much.
Thank
All
you.
right.
This
You're
was
welcome.
so educational.
Thanks.
Thank you for your time, Dr. Boone.
Of course. All right. I'll head off so you guys can talk. Let me
Well,
stop
we
this.
appreciate you.
Of course. All right. Take care. Thank you, everybody.
Thank
Have a good
you.
evening.
Have a great night.
Bye.
And thank you for listening on Osteo Boston tonight. And we will be talking to our group right now. Thank you.